All right, I want to thank everyone for joining us this afternoon for our Foundations curriculum. We are in for a really exciting lecture today by Dr. Marjorie Makoni, who is an associate professor, neonatologist, and the T&E Hemodynamics Program Director at Oklahoma Children's Hospital. Her clinical and research interests include chronic pulmonary hypertension, racial disparities in premature babies, genomics, and meta- meta- Marjorie's gonna have to help me with that word, of cardiovascular development in premature infants. Just a reminder for everyone, our next lecture will be on November 12th. It's off cycle 1 week. And that is going to be on the topic of chronic pulmonary hypertension and BPD by Dr. Mike Castaldo. We want to thank everyone at Mallinckrodt who have provided an unrestricted educational grant that supports the Neonatal Hemodynamics Foundation's curriculum. As a reminder, this is also now accredited by a self-approved group learning activity with the Royal College of Physicians and Surgeons in Canada. And then finally, a little bit of a plug for another really important and very educational conference that is going to be going on, the Dr. Reagan Giesinger Clinical Cardiopulmonary Physiology for the Care of the Sick Newborn course. That is going to be November 3rd through the 6th, so just a little over a month away. Has some really outstanding speakers already lined up, is a really great conference. We have the QR there, and I think Laura was going to place a link as well in the chat. So please definitely sign up for that. As a reminder, with the structure of our talk today, we will have Marjorie speak first, go through her talk, then have a little bit of some time for Q&A before we then ask our junior faculty and trainees who will join for the for the case conference, and reminder that that will be in a separate link in chat. And I'll remind you all of that at the end. So I'd like to welcome Marjorie. Really excited to hear you talk today. I love whenever you speak to us. So take it away, Marjorie.
All right. Thank you very much. I will share my screen. All right, perfect. So I am really excited this afternoon to be talking about acute pulmonary hypertension characterized by persistent fetal circulation. We'll recap pathophysiology, physiologic principles, therapeutic combinations, and lastly, a case in the next session. So acute pulmonary hypertension occurs when there's a failure of the normal decline in pulmonary vascular resistance at or shortly after birth. The hallmark of APH is sustained elevation of pulmonary vascular resistance with labile hypoxemia. This results in elevated pulmonary artery pressure, which may be associated with impaired right ventricular systolic performance or RV dysfunction, RV systolic dysfunction. So very briefly, in the fetal state, high PVR is maintained throughout gestation by increased vascular tone and muscularized pulmonary arteries that are adapted to a tonic low-energy vasoconstriction state. At birth, lung aeration distends these blood vessels and reduces turbulence by stretching these somewhat kinked blood vessels. The rising pressure of partial pressure of oxygen, rather, and endogenous vasodilators also lower vascular tone. So these pulmonary artery smooth muscles that are organized in these brick-like shapes are elongated into spindle cells, and the vessel lumen enlarges. By 2 weeks, pulmonary arterial muscular thickness decreases markedly, and that contributes to sustained decrease in pulmonary vascular resistance, as you can see right here. So there's also a series of events that occur during labor, and the process continues at and after birth. At birth, there's transition from fetal to neonatal circulation, And this usually involves increase in systemic vascular resistance when the low um, placental system is cut when you clamp the cord. And then you also have a fall in pulmonary vascular resistance. This usually results in 8 to 10-fold increase in pulmonary blood flow, and that enables gas exchange. So these changes lead to flow reversal at the PDA, closure of the PFO, and converting the circulation from parallel to series with balanced ventricular outputs. In persistent pulmonary hypertension, when this transition fails to occur, we have sustained right to left PDA shunting, PFO shunting, and sustained pulmonary vascular resistance that is high. So during this critical transitional period, pulmonary circulation must dilate to accommodate the entire cardiac output. This then becomes the main source of preload to the left ventricle. So already you can kind of see if that process does not occur, that you already have some problems of preload to your LV. Elevated pulmonary artery pressure also occurs via alternative mechanisms, and this includes flow-mediated mechanisms as well as downstream pressure, for example, in LV diastolic dysfunction. Today, we'll be focusing on resistance-mediated or pulmonary arterial hypertension. There are three main etiologic groups of acute pulmonary hypertension characterized by persistent fetal circulation, and these are maladaptation, in which the pulmonary vascular development is actually normal, but the pulmonary blood vessels have abnormal reactivity in response to hypoxemia. And there are many differential diagnoses under this group of pathologies, and they encompass up to 80 to 90% of acute pulmonary hypertension. And then there's also maldevelopment, in which the vascular architecture is abnormal, and this is characterized by increased smooth muscle thickness and abnormal distal extension of muscle into normally non-muscularized vessels. And then we also have pulmonary hypoplasia, which we usually see for more term babies, congenital diaphragmatic hernias, and in our preemie population, prolonged premature rupture of membranes, in which there is an underdeveloped vascular bed. So the clinical presentation, much like most pathologies in neonatology, is on a spectrum. They can start with mild hypoxemia and stay there, or they can present with severe cardiopulmonary instability. Some of the clues that point towards acute pulmonary hypertension are hypoxemia out of proportion with chest X-ray findings, and of course that labile oxygenation. And then upon further evaluation, when you obtain an echo, not if, shunt physiology can also give you a clue in terms of PDA, PFO directionality and magnitude. And also sometimes there are multiple lung and vascular pathologies that coexist. So a lot of times we talk about predominant physiology because we know that there could be more than one thing happening at the same time. So at a cellular level, there is endothelial dysfunction. Irregardless of what the inciting event was, it could be inflammation, it could be hyperoxia, it can be chronic hypoxia from maternal factors such as chronic hypertension, preeclampsia. All of those things will lead to some degree of endothelial dysfunction. So this endothelial dysfunction is really shows you that there's so many different factors that can affect how the smooth muscle cells contract. So there's an imbalance of signaling pathways, vasoconstrictors such as endothelin 1 and serotonin drive vasoconstriction and smooth muscle proliferation, as you can see with the very many arrows here. And along with that, some of the factors such as inflammatory markers, cytokines, can also potentiate these vasoconstriction properties. And then vasodilator pathways such as nitric oxide, prostacyclin are blunted, and at the same time, you have growth factors such as IGF, IGFR, and VEGF that are dysregulated, promoting abnormal vascular remodeling and sustaining this high resistance state. So essentially, what we have is a balance that tips towards vasoconstriction and remodeling, while vasodilator pathways are blunted, leading to sustained high pulmonary vascular resistance. It's a very busy slide, but I hope I did a good job of breaking those down for you. And then at the myocardial level, this persistent elevation in pulmonary vascular resistance and increased afterload on the RV results in an initial adaptive hypertrophy, which is referred to as homeometric hypertrophy. And this happens by increasing myocardial contractility with maintained RV to PA coupling. However, so that is this diagram in the middle. However, if this increased afterload on the RV persists, the RV then dilates, damaging the RV contractile apparatus by lengthening the individual sarcomeres beyond the optimal interactive capacity, leading to poor contractility, RV dysfunction, therefore RV to PA uncoupling. And that is referred to as heterotrophic adaptation. In addition to that, there's also, because of the high afterload on the RV, there's bowing of the interventricular septum into the left ventricle, which reduces pulmonary venous return and leads to reduced left ventricular preload and output, resulting in diminished systemic perfusion, right to left shunts at the PFO and the PDA, and this contributes to systemic hypoxemia. Systemic hypoxemia and hypoperfusion reduce coronary perfusion and pressure, and exacerbates myocardial ischemia and ventricular dysfunction further. So when you put this all together in a box system that encompasses all the elements we talked about, you can see that high RV afterload is at the center of this havoc. At the center of RV adaptation to increase afterload, or PVR in this case, there's this law of stress velocity, which is determined by pressure, which is afterload, increased PVR, chamber radius. We talked about dilation of our RV, and H, which is wall thickness, the adaptive response of hypertrophy that we talked about. So when we have sustained pulmonary vascular resistance or afterload, the RV dilates. It hypertrophies first, then you have dilation after that, then you have increased wall stress and contractility. Contraction velocity decreases and you have dysfunction that develops. So this is a very important relationship to keep in mind. The neonatal myocardium, especially the RV, adapts very poorly to afterload, as we have just talked about. But these following diagrams will give you a better idea of exactly how profound this effect is of RV, of afterload on the RV. So the RV has a different shape from the LV. While the LV is cone-shaped, has thicker walls, and is equipped to function under conditions of increased afterload, the RV is a little different. It is designed to function more as a flow generator, accommodating the entire systemic venous return to the heart. So as wall stress increases, contraction velocity, I started with this diagram, as wall stress increases, contraction velocity, as you can see, decreases very profoundly in the RV. That's why it doesn't perform well when there's increased wall stress. And then in this diagram here, the ejection fraction of the RV, so up here is the LV, and here we have the RV. As pressure increases on the RV, the ejection fraction also has a very steep decrease. And you can see this with the representation of the RV afterload that I showed you prior. And then again here, just for completeness sake, the stress velocity relationship on mean airway pressure and stroke volume also shows that the neonatal RV, when compared to the neonatal LV and the adult ventricles, really does decrease stroke volume when there is increased afterload on the ventricle. And then this is one of my most favorite laws in, in physiology. So because the RV is uniquely sensitive to afterload, Darcy's law helps explain the physiology in acute pulmonary hypertension, where pulmonary blood flow is determined by pressure gradient. So the pressure gradient is between the mean pulmonary arterial pressure and the left atrial pressure divided by pulmonary vascular resistance or resistance here, which in our case is pulmonary vascular resistance. So when PVR remains high, RV afterload rises, flow decreases or falls, and the RV decompensates despite generating high pressures. So Dawson's law is really provides a conceptual framework to understand that the problem in acute pulmonary hypertension due to persistent fetal circulation, it's not just pressure elevation, but fundamentally it's resistant mediated flow limitation. And this is a very important concept. So cannot talk about acute pulmonary hypertension without paying attention to the alveoli and what is happening there. So in acute pulmonary hypertension, neonates and children usually have some trigger, which is a primary lung injury, whatever etiology it is. The one mechanism that is associated with this is the hypoxic pulmonary vasoconstriction. This is a very important mechanism by which the lungs and pulmonary vascular bed match ventilation and perfusion. So this is where the VQ mismatch would come from. So it is biologically advantageous for well-aerated air spaces to receive the bulk of pulmonary blood flow through local vasodilation mediated by the presence of high partial pressure of intravenous oxygen, what we talked about a few slides ago. And a low partial pressure of oxygen leads to localized vasoconstriction, which diverts blood away from poorly ventilated areas. That's how you end up with VQ mismatch. So if you have a dysregulation in this process, then you have hypoxic alveolar constriction, and that leads to potentiation of pulmonary vascular resistance. All right. So how do we approach evaluating the neonate with acute pulmonary hypertension? So most importantly, remember when they come in, they don't come in saying, oh, I have pulmonary hypertension. They show up and they have some sort of hypoxemia. Usually they present with acute hypoxic respiratory failure, or they have a low oxygen saturation requiring a lot of oxygen, and sometimes they can be hypotensive, requiring other therapies as well. It is important to note that taking a very good prenatal history can often provide clues to the underlying physiology of neonatal cyanosis, which is how most of these babies present. Oligohydramnios due to prolonged rupture of membranes in the second trimester, renal abnormalities, or polyhydramnios, all of those can be associated with lung hypoplasia, leading to hypoxic respiratory failure. So it's very important to tease those out. Whether this baby comes to you right from the delivery room or as a transport from another place, it's still very important to obtain that prenatal and perinatal history, because sometimes it can give you half of the story that you need in order to manage these babies appropriately. Prolonged rupture of membranes can increase the likelihood of developing early onset sepsis, congenital pneumonias. So it's very important to tease that out. History of meconium stained fluids increases the likelihood of meconium aspiration syndrome. Cardiac and respiratory compromise may follow perinatal asphyxia with hypoxic ischemic insult to the myocardium. Knowing about the risk for HIE, also perinatal asphyxia is very important in these patients. So pulse ox can be used to detect neonatal hypoxemia. Usually, a preductal saturation probe should be placed on the right arm and a postductal on one of the feet, because sometimes as there's a normal variant where the left arm can also have uh, preductal blood supply. So it's best to put your postductal pulse ox on one of the legs if it is possible at all. So respiratory distress is characterized um, is a characteristic of pulmonary lung parenchymal disease, which may occur on its own or with concurrent pulmonary hypertension. So usually, sometimes, uh, these babies present with cyanosis. They present requiring hefty, moderate to really high ventilator settings. May not necessarily be acute pulmonary hypertension. So that's also good to keep in mind. Hypoxia out of proportion to the magnitude of respiratory distress should raise concern for disordered pulmonary blood flow, high preductal oxygen saturation in the feet. Suggest acute pulmonary hypertension with an open ductus, but also some other form of congenital heart disease. But it's always important to keep in mind that even if you have a patient who lacks the pre and post ductal saturation difference, that does not exclude a diagnosis of acute pulmonary hypertension. There is a subset of patients who, when they have prenatal post ductal closure, can present with acute pulmonary hypertension, RV failure, and those babies usually have shock-like clinical appearance. For completeness sake, the evaluation should be pretty extensive, not just an echo. I know this is a hemodynamics lecture, but that perinatal history, as I mentioned, your cord blood gases, physical exam, listen for those bruits. It helps you rule out the etiology of your cyanosis, chest x-rays, abdominal x-rays, head ultrasounds, if you do hear those bruits, and sepsis evaluation, of course, antimicrobials and comprehensive echocardiography. This is a schematic with some representative chest x-rays, courtesy of Dr. Satyan, of some of those etiologies of acute pulmonary hypertension. So this kind of touches on the three groups that I talked about: the maldevelopment, pulmonary hypoplasia, most commonly in our population, congenital diaphragmatic hernia, delayed transition, that can be just TTN, asphyxia, and of course, intravascular obstruction. Sometimes polycythemia too, hyperviscosity can present with the similar findings. So it's really important to include that in your evaluation. So you've done your physical evaluation, and now you're asking for a comprehensive echocardiographic evaluation. The five main things that you're looking for. One of them is to rule out congenital heart disease. Absolutely always rule out congenital heart disease. Then you want to evaluate pulmonary artery pressure. You want to evaluate pulmonary vascular resistance, and you want to evaluate ventricular performance, both RV, LV, and your shunts, what they're doing. This is a very extensive list of parameters to evaluate in your echocardiograph. So I know a lot of places don't have TNE. This here can help you refine your question to cardiology in order to help guide management of your patients. And again, these babies can indeed have multiple physiologies occurring at the same time, but this will help you tease out the predominant physiology. So here we have evaluation of pulmonary pressures and resistance. So we usually use systolic eccentricity index, the TR jet, quantified by RVSP and modified Bernoulli equation. I'll talk about that a little bit more in the next slide. And of course, RV ETPAT, to evaluate RV performance, RV fractional area change, which is not really something you find in the usual cardiology echo, but in a TNE echo, we will report that. And then tricuspid annular planar systolic excursion, TAPSE, should be available in all echoes, and right ventricular output. And then to evaluate LV performance, we look at ejection fraction by Simpsons, and we prefer Simpsons because it's independent of septal flattening, and I will explain in the next few slides. LV output, as well as pulmonary vein Dopplers as surrogates for pulmonary blood flow and LV preload. And of course, our shunts, PDA estimates relative PA pressure versus aortic pressure, PFO estimates relative RA pressure versus LA pressure, and VSD estimates relative RV pressure versus LV pressure, and of course, ruling out congenital heart disease. So pulmonary artery pressure, common measurements again, TR, systolic eccentricity index, and TR is usually not reliable in the presence of RV failure or RVOT obstruction. So when you read that, when you get that cardiology echo, and you're looking through all the words and all the numbers, it's very important to keep in mind that we should be using more than one parameter, and we should be mindful of all the different components of that evaluation. So TR-JET is usually present in 60 to 85% of patients with acute pulmonary hypertension. And this can be obtained through so very many different views. So there's 4 options. In one of these, you should be able to obtain TR-JET only if it's there. Sometimes it's incomplete or it's not present, and that's okay. So we move on to LV eccentricity index, where we look at the relative shape or displacement of the intraventricular septum. This is the RV here. This is the LV. So it would be this measurement right there. And I'll show you here in the next slide. So if you have a systolic eccentricity index around 1, usually means you have no or mild pulmonary hypertension and your septum is round. If you have SEI that is greater than 1, specifically greater than 1.3, you have a D-shaped LV. The RV pressure is usually half to 2/3 LV pressure, and then a paradoxical usually means severe pulmonary hypertension. As you can see, these are the representative images of the echoes that you would see. And again, always beware, false negatives can happen, especially if there is systemic hypertension. And also, this is impacted by RV and LV systolic function. So this should be, all of these measurements should be interpreted with caution. Pulmonary vascular resistance through pulse wave Doppler at the pulmonary artery. The shape of the PA Doppler envelope usually gives an idea, as well as the number, obviously. Isosceles triangle, usually associated with no mild pulmonary hypertension. An acute angled or right-angled triangle usually signifies high PVRI, which is greater than 4. And then if you have notching, that usually means suprasystemic or severe pulmonary hypertension. And then evaluating those ventricles, you can see RVFAC, which is fractional area change. And here you can see, you can get a TAPSE on the RV free wall, and that'll give you the TAPSE, which is a distance measure, the upward or downward displacement of the tricuspid annulus, tricuspid valve annulus. And then, of course, shunt directionality of your PDA can also tell you severity, where bidirectional, usually half to 2/3 systemic, and then right to left, usually suprasystemic pulmonary hypertension. So putting all this together with a representative schematic on a patient with meconium aspiration syndrome. So we have this baby with this pulmonary vascular disease. where they have alveolar collapse in some places and alveolar distension in other places. That results in hypoxia and acidosis. You have remodeling of the pulmonary arteries and they're constricted. That results in increased pulmonary artery pressure or increased PVR, increased pulmonary artery pressure, decreased pulmonary blood flow, plus um, pulmonary capillary wedge pressure. That is increased afterload on the RV, which then hypertrophies, as you can see here. Then your PFO is right to left. The PDA is right to left. You have systemic hypoxemia and differential cyanosis. As you can see, the right arm is less blue than the feet that are more blue. And then you end up with low pulmonary venous return, decreased LV output, decreased coronary perfusion, and myocardial ischemia. So the goals for therapy are to address the problem of pulmonary blood flow. And to achieve that, we optimize lung recruitment in a very disease-specific manner. For babies with RDS, we can use surfactant, and we also employ targeted effective pulmonary vasodilation. And first line is usually INO. We use those strategies to improve pulmonary blood flow. If we need inotropy to improve ventricular function, then we very disease specifically, physiology specifically, choose the inotropes that are needed. If we need vasopressors, we need vasopressors that are more physiologically friendly or optimal for the patient, and that will help us improve oxygenation, blood pressure, and coronary perfusion, as well as systemic perfusion. So our goals for therapy are in conjunction with supportive therapies that are not limited to just the ventilation, inotropes, lung things, but also should include your electrolytes, your calcium, don't forget those, and sedation, quiet environment, and of course, other therapies such as corticosteroids that are needed. In our quest to optimize the lung condition, we should be mindful that in instances of low lung volume, we can have alveolar hypoxia, hypoxic pulmonary vasoconstriction, and high PVR. And in cases of excessive lung volumes, this would usually be overextension or excessive mean airway pressure. We can have excessive lung volumes that cause alveolar overdistension, compressing those vessels and resulting in high PVR. Both underexpansion and overexpansion elevate PVR, increase RV afterload, which would potentiate the cycle, the vicious cycle that's already happening. And then sometimes that also blunts the response to inhaled nitric oxide. So maintaining a balance is of utmost importance here. All right, so our respiratory goals, I won't spend too much time on this. There's not a lot of studies that have shown us what the appropriate SpO2 levels are, but just from knowing the higher affinity for fetal hemoglobin for oxygen, we recommend 90 to 95, and then pH, not acidotic, obviously, because acidosis stimulates vasoconstriction. Postductal PaO2 60 to 80. Most of these babies will have UVCs, but if you do have preductal PaO2, that was left blank to encourage discussion later. But usually there are studies that have shown that a preductal PaO2 greater than 50 does not give you much more pulmonary vasodilatory effects. PCO2 35 to 45, as animal studies have shown that hypoxemia, alveolar hypoxia and hypoxemia stimulate pulmonary vasoconstriction. And then moving on to the pulmonary vasodilators, INO is first line in pH, in acute pH, where LV function is preserved and RV the function is coupled. Usually we start with a dose of 20 parts per million, and then you wean when appropriate to minimize reactive oxygen species. Clinical response is usually seen when your partial pressure of oxygen goes up by 20 millimeters of mercury. Uh, Always remember to monitor your methemoglobin daily. And then non-selective pulmonary vasodilators can also be used. The most common one that we use is milrinone, which is used for synergy. It has lucitropy and is an anodilator, usually in pulmonary hypertension with LV, RV dysfunction. And then, of course, PGE can be used to offload RV pressure with some pulmonary vasodilatory effects, as well as maintaining PDA for right to left shunting when you have single ventricle physiology. So basically, the therapeutic approach is to decrease pulmonary artery pressure and PVR, increase pulmonary blood flow, preserve RV performance, facilitate systemic blood flow and organ perfusion, restore diastolic blood pressure to maintain coronary perfusion pressure, and minimize tachycardia. And then to the good part, the when and if inotropy is required or needed, dobutamine is a contender that is a pure positive inotrope. It has increases contractility via alpha 1 receptors and also increased heart rate. It is not known to have any effect on SVR, systemic vascular resistance. And the dose is usually from 2 to 20 mics per kilo per minute. Usually people max out at 10. Beyond 10, you usually end up with more tachycardia that you need, and it offsets the force frequency relationship, and you end up uh, not making any progress. And epinephrine also increases contractility and heart rate via alpha 1, beta 1 receptors. At low dose, it has zero or no effect on SVR, but more, and at high doses, it has more vasoconstriction effects. Doses greater than 0.1 mics per kilo per minute are not usually utilized because you end up with more SVR and more tachycardia than you would prefer. And then milrinone, as I mentioned in the slide before, the increases contractility, but it's non-selective vasodilation, so it also decreases your SVR as well as your pulmonary vascular resistance PVR, and increases pulmonary blood flow. So that has to be used very cautiously, especially in patients with AKI, acute kidney injury as well, and decreased urine clearance, because that is how it's cleared. So if patient is hypotensive, it's probably worth it to wait, increase your systemic blood pressure, and then start milrinone if it's required. And then dopamine, I put it there because a lot of centers still use it. We still get a lot of babies that come here on dopamine, but it's not usually the preferred vasopressor, especially given its effect on pulmonary vascular resistance, which is higher than you would want in a baby who already has increased pulmonary vascular resistance. And then norepinephrine, if the babies have intact function and you need vasopressor, norepinephrine is a good option. The doses are 0.02 to 0.5. It has minimal effects on contractility, minimal to no effect on contractility, and heart rate as well. And then vasopressin increases release of nitric oxide, has maybe minimal effects on pulmonary vasculature when the mechanism is yet to be described, but it has been used in conjunction with INO and milrinone, commonly known as the MVP approach in babies with acute pulmonary hypertension. And the dose usually from 0.1 to 2 milliunits per kilo per minute. And we have to be mindful of sodium supplementation when patients are receiving vasopressin. Usually, if vasopressin is to be given for more than 48 hours, that's when we find there is some issues with hyponatremia. And this is usually a dilutional hyponatremia. Strategies that have helped in mitigating this hyponatremia is having a higher baseline sodium level or increased sodium supplementation during the duration of vasopressin. And then hydrocortisone increases endogenous epinephrine release, increases expression of adrenergic receptors as well. Onset is usually of action is usually 2 to 6 hours, and it can be used as an adjunct, anti-inflammatory in meconium aspiration, pneumonia, or an infection. And also, if there's adrenal insufficiency, especially in HIE, prematurity, pneumonia, or any of the etiologies of acute pulmonary hypertension. And sometimes, even if there's no inflammatory condition, some centers use hydrocortisone. They usually have some protocol that says after one or two or more pressors or inotropes, you add hydrocortisone. And then prostaglandins, as we talked about in the adjunct slide, can be used for the additional vasodilatory effects in severe pulmonary hypertension. And then, of course, in univentricular physiology, they can be used to uh, maintain, to support both systemic and pulmonary circulation. So you have this patient who's come in, has hypoxia, you've optimized your ventilator, you've recruited your lungs, everything looks perfect, you've ruled out pneumothorax, then you get your echo. You find the baby has acute pulmonary hypertension. You have investigated and done all the other treatments that you do. You start your INO, you have no response or partial response, but you have low systemic arterial pressure. What would you want to know from an echo, and what would help you with your management? So this is where knowing your RV function and your LV function would be helpful. So this diagram kind of helps figure out if you have RV dysfunction. Do you start dobutamine, epinephrine, or just start prostaglandins? Usually you don't just start prostaglandins as first line. You start the inotropes first. And then if you have a restrictive or closing PDA, you could use prostaglandin for maximum benefit in that situation. And then if your RV performance is normal, then that's where you look to using vasopressin, norepinephrine, and hydrocortisone as well. So this is just kind of a systematic approach to how you would. And then I can stress enough the importance of serial reevaluation. Whether you have TN echo or cardiology echo, you can always follow up on your echo to see or gauge response to the therapies that you have started. Sometimes if the baby's not responding, it's not that you did the wrong thing or you did not do the appropriate thing. Sometimes you just need to increase, adjust, or add an adjunct to optimize therapy for your patient. So the fundamental principles of combination therapies are targeting multiple pathways, balancing pulmonary and systemic effects. You don't want to decrease your PVR so much that you also decrease your systemic vascular resistance. So you have to strike a balance between those two. And it's absolutely important to preserve your systolic blood pressure and your diastolic blood pressure to maintain coronary perfusion. Inotropes and vasopressors are usually needed alongside with those vasodilators to support RV function and systemic perfusion. And then, of course, always remember synergy and not redundancy. You can use the two different vasodilators from two different pathways to for an additive effect by targeting those pathways in that example that I gave there. And then, of course, tailor to the patient. Some combinations work best in selective phenotypes. And then also choose therapy based on hemodynamics, oxygen response, RV function, and systemic blood pressure. Monitor carefully and evaluate serially. The take-home message is in acute pulmonary hypertension, combination therapy is most effective when therapies target different signaling pathways, reduce pulmonary vascular resistance while maintaining systemic perfusion, and supporting RV function. Thank you. That is all I have today.
Thank you, Marjorie. Sorry, I was struggling to get my audio back on. Thank you for that wonderful talk. Really, really great. I'll remind our attendees if there's any questions to go ahead and put them in the Q&A. We'll um, have a few minutes from the general audience for Q&A before we switch over to just the small group session. While we wait for some questions to come in, Marjorie, what we get asked all of the time about from our trainees how I go about picking vasopressin versus norepinephrine if I feel like I need a vasoconstrictor. What do you tell, how do you practice? What do you tell your trainees? Oh, Marjorie, you're muted.
Oh, sorry. Yeah, that question that question comes up a lot. How we when to start vasopressin versus norepinephrine. I think if the baby is not requiring a lot of FiO2, if they're not in 100% FiO2, because I tend to follow evidence-based medicine based on those studies that say, there is some increased pulmonary vascular resistance with norepi when your FiO2 is that high. Then I tend to uh, shy away from using norepi in those patients, and I go for vasopressin. But for vasopressin, there's also the balance between what is my starting sodium. If a patient has sodium of 128, that is a baby that we probably would start norepi while we attend to or fix the hyponatremia. And then once that is corrected, then we can uh, change over and give vasopressin. It tends to be a very hot topic around here, and a lot of people have a lot of feelings and opinions about it because there's just not a lot of literature that talks about vasopressin. So it becomes very difficult.
Agreed. Yeah. I feel like if we reserve vasopressin for the babies who we feel like really strongly need it, or the ones who have, severe pulmonary hypertension, with the goal of trying to stabilize them and then trying to work to get off transition from vasopressin to norepinephrine if you still need something much after 24, 48 hours for sure. So, but yes, always comes up when you talk
Mhm.
about it.
Always, always, yes.
And then another great question from our audience. So, any tips or tricks on treating pulmonary hypertension when you don't have INO available to you? Even for those centers who, even for our trainees, maybe the baby's out on transport and you didn't realize they were as sick as they are, you didn't send nitric, or for the centers who are working to stabilize the baby without INO present.
So, there is a study, and pardon my, I don't remember exactly where they showed that sildenafil, IV sildenafil, can be used in low resource areas who do not have nitric oxide, has been used when INO is not available. But the non-specific nature of vasodilatory nature of sildenafil makes it a little challenging because when you run into systemic hypotension, then you're going to want to start using pressors, and those pressors are going to increase your pulmonary vascular resistance. And then you end up in this vicious cycle where your baby is just stuck in one place. I probably would recommend if there is another place the baby can be sent where they have INO, that would be a good option. But if you don't, then obviously, and there are other pulmonary vasodilators as well. We used to have iloprost. I don't think they make that anymore, but there's also epoprostenol that can be utilized in places where INO is not available. Um, And then depending on, I talked about the other lung disease-specific lung therapies such as surfactant. We can use that when, of course, you've made sure that your LV is functioning appropriately and that it fits that patient to use that. And then if you have milrinone and you don't have INO, it has some degree of pulmonary vasodilatory effects as well as vasopressin. So it just becomes a balance of what is your baby needing and what do you have available to you? How far is the next place that where you can send the baby? But there are other pulmonary vasodilators that you can use. Then others such as bosentan that I didn't even talk about, they are available, but we don't usually use those in the acute setting. Those are usually for the more chronic type of pulmonary vasodilation. And then, of course, PGE also has some vasodilatory effects that we can utilize prostaglandins or alprostadil for the people who use that nomenclature. So there are definitely other things that we can do. I know it's just first line because it's very selective. You're sending it exactly where it's needed. It's going into the lungs as long as you optimize the lung condition. So with INO, you might find faster recovery of your patient. And then with all the other adjunct therapies, since they are non-selective, you might find yourself in a bit of a struggle. I Fortunately, I have not been in that situation where there was no INO for to know exactly how this might play out if you actually don't have INO. But I think that with careful titration of all those other different pulmonary vasodilators, you could probably achieve. And then, of course, I can imagine if you do not have availability of INO, would you have ECMO available? Because that might be something that your patient ends up needing extracorporeal membrane oxygenation for, for treatment of ECMO, which, sometimes happens if you reach maximum therapy and your baby does not respond, then you end up going that way. So if that's an option, then that is available. Then we utilize that as well.